Good afternoon, everybody. First of all, I would like to express my sincere gratitude for inviting me for this lecture. And already you have listened to a very comprehensive lecture regarding the chest pain in acute condition. Further, I would like to share my knowledge regarding chest pain in stable patient with you. In this presentation, I briefly explain what is stable coronary artery disease and what is why the chest pain is important and how to get a very good clinical history and including risk factors to analyze the chest pain, and how to calculate the probability of having coronary vascular disease, because that is the basic of managing stable coronary artery disease, and how to plan the further investigation according to the probability, and basics about exercise CCG and CT coronary angiogram, and how to what is the current status at Nuwara and how to improve the situation at Nuwara. We all know that the management strategies has significantly improved in related to cardiovascular disease over the last few decades. Therefore, the survival has steadily improved. However, still the number one cause of death in related to hospital admission is cardiovascular disease. And the situation is similar in Sri Lanka. The 40% of deaths, hospital deaths, is due to cardiovascular disease. We all know that the chest pain is the commonest clinical presentation in related to cardiovascular disease, and that is the most common, one of the most common clinical symptoms we daily see in OPD and emergency departments. The Dr. Koglan basically discussed about how to analyze the chest pain in emergency department. I am basically targeting how to analyze chest pain in OPD. Okay, what is OPD at Nuwara? We know that we have a very good outpatient department where we see thousands of patients daily. However, at Nuwara, the OPD include all the other health institutions, especially medical centers, because thousands of patients are seen by doctors at dispensaries. Sometimes most of them are even not come to hospital. Therefore, analysis of chest pain in stable patient includes the patients in these institutions as well. Okay, few more things regarding statistics about stable chest pain. About 60%, that is more than half of the patients, chest pain is not come from organic. That means we know that chest has three main organs: cardiovascular system, respiratory system, and part of the gastrointestinal system. And the 60% of the time, the chest pains are not coming from these three main organs. It starts from various other small structures such as skin, bone, even from higher centers like psychiatry. Okay. And further, if I tell the same thing in a different way, the only 52% of time the chest pain is due to musculoskeletal diseases, and 20% time it is gastrointestinal, that is mainly gastritis, and 12% psychiatric. Only 16% is due to cardiac diseases. Out of this 16%, 14% is stable, and only 1.5% cases are due to acute coronary syndrome. However, we all arrange our investigations and management strategies to diagnose this 14% and 1.5%, because that is the main killer of chest pain. Okay, one more thing regarding statistics. It has shown shown that 88% of time doctors were able to diagnose chest pain by clinical history and examination. That means in 12% of time we have failed to diagnose the reason for chest pain. Therefore, I think upgrading the knowledge regarding this analysis of chest pain and further investigation, it is very important even to keep this 88%. Okay, from here onwards, I will explain step-by-step approach to analyze the chest pain in a stable patient. Even though these patients we see, as I said, in OPD, in our clinic, and in our dispensaries, as well as in our day-to-day activities. As a doctors, we have to answer patients' clinical problems, not in the medical insurance. Sometimes when we are going for a party or when we are going for a wedding or funeral, they tell they are all medical problems to us. The chest pain is one of the most common symptoms they present like this. Okay. Even though the patient is very stable, hemodynamically stable, our step 1 should be targeting to exclude life-threatening causes for chest pain. There are 6 life-threatening causes. We have to first exclude these 6 life-threatening causes by asking very basic few questions. Those 6 causes include tension pneumothorax, aortic dissection, acute myocardial infarction, esophageal rupture, pulmonary embolism, and perforated peptic ulcer. Okay, step 2 is mainly targeted to find out the specific cause for chest pain. There are hundreds of causes for chest pain, but we have to find out exact cause. But our target is by getting a good history and doing examination and arranging basic investigation, not to exactly find out the reason, actually basically to exclude the coronary vascular disease, because as I said earlier, that is the number one killer for all chest pain causes. Detailed history. We all have learned during our medical school, and then we have practiced throughout our medical career how to get a good clinical history regarding chest pain. That include getting chest pain regarding assessing its quality, aggravating factors, relieving factors, associated symptoms, and other things. I am not going to discuss those things here, but I will tell few more information regarding angina. Angina basically defined as a chest pain or discomfort due to insufficient blood supply to the heart muscle. That is a mismatch, that imbalance between the oxygen supply and oxygen demand of the heart. And it has few characteristics. Usually angina lasts minutes, not seconds or not hours. And location is usually substernal, and it can radiate to neck, jaw or epigastrium or arm. And usually it is precipitated by physical or emotional stress, both physical and emotional stress, and relieves by rest. And we commonly use GTN, it usually relieves with GTN and GTN. Those are the typical features of angina. Okay. After getting a good clinical history about chest pain, we all should able to classify all chest pains into these 2 classes. Dr. Kogulan already told these 3, that is a typical chest pain, atypical chest pain, and non-cardiac chest pain. That is our main simple target. Classify chest pain to one of this group according to the clinical history. I will explain it later, because I am highlighting this because all the clinical researches which was done over the last few decades, that was thousands of researchers, and all the guidelines prepared at various countries based on this classification. I don't know, still our physician and we basically does not follow this classification very much. But I think it is very important to follow this classification. Okay. Before that, after getting a clinical history regarding chest pain, we have to ask about risk factors as well. Risk factors means risk factors for the coronary artery disease. These 5 are the main risk factors which cause coronary artery disease. That is diabetes mellitus, high blood pressure, smoking, high cholesterol, and family history. Here I am not going to discuss much more things, but one word regarding high cholesterol. We all know cholesterol is very important. Daily we do lipid profiles of patients, but still I think the analysis of lipid profiles report is not happened correctly. All the lipid profile reports give reference range for total cholesterol and LDL, but that is not the correct thing actually. The reference range for total cholesterol and LDL basically varies from patient to patient. Therefore, in future when we are analyzing the lipid profile, we have to get patients differently. Okay, this was very well described in a very recent guidelines published by European Society of Cardiology in 2019 lipid management guidelines. We have to assess the patient overall cardiovascular risk. According to the cardiovascular risk only, the LDL target and total cholesterol target given. Then only we can diagnose whether this patient have high cholesterol or not. Okay, this is basically the chart. If you go in detail, here it gives the target cholesterol level and how to manage, and what are the who are the patient who need lifestyle modification only, and who are the patient need medication, and what is their LDL and total cholesterol target. This is not the topic today, but because of the importance, I just want to share this slide with you. Okay, again go back to our classification. These are the 3 types of chest pain: typical angina, atypical chest pain, and non-cardiac chest pain. Okay, typical angina has three main features. Okay, that I label as 1, 2, 3. It's a substernal chest discomfort. Second feature is provoked by exertional or emotional stress, and third feature is relieved by rest or GTN. If patient tell these three features are there, that is called typical angina. Okay, I am highlighting this because all the further management depends on this classification. And the atypical chest pain is if there is two criteria that is mentioned in above, means it is called atypical chest pain. And non-cardiac chest pain is if there is one feature or none of them are present, it is called non-cardiac chest pain. As an example, if a patient comes with right-sided chest pain, which is not increased with exertion and happens occasionally, that is we can categorize it as a non-cardiac chest pain. I hope that in future, if we get a cardiology referral, you can present the history according to this classification. Okay, and after classifying chest pain, this is the next step. We have to assess the patient's probability of having coronary vascular disease. Okay, yes, that means how much percentage of patient is having coronary artery disease. Okay, this is a very basic. I would like to highlight the landmarks in the chest pain assessment history. You know that in cardiology there are thousands of researchers doing every day. These are the main landmark points in the history. In 1979, Diamond and Forrester basically made a model to assess the stable coronary vascular disease according to that chest pain classification, and then it was changed few things, but in 1993, according to the Duke database, it was further developed. And based on these initial steps and researches, various countries have their own guidelines, basically to how to investigate stable coronary artery disease. In 2012, American Heart Association published their guidelines, and they have updated in 2014. In 2013, European Society of Cardiology, they have updated their guidelines regarding the guidelines for stable coronary vascular disease. United Kingdom, they have published NICE guidelines several times, and very recently, that is in 2016, they have updated their guidelines. Again, European Society of Cardiology, they have updated their guidelines in 2019, and they have changed the stable coronary artery disease also to as chronic coronary syndrome, like acute coronary syndrome, chronic coronary syndrome. Okay, where are we? We have threatened to select one, but still we have not, and most of us follow all the guidelines, and very unfortunately, some of us does not follow any guidelines. Okay. Again, going back to that 1979 Diamond and Forrester, they have assessed the patient clinical history, and as I said, categorized chest pain into three main groups, and they assess and calculate the probability of having coronary artery disease according to the patient's age and sex. And this is the ultimate chart they have given. In here, you can see that red color dot says, the square says 89% and 93%. That means if the patient age is more than 80 and if they have typical angina, the patient has 93% of chance having coronary vascular disease. On the other side, the right upper corner says number 5. That means if a woman comes with age between 30 to 39, if the pain is non-anginal pain, she has only 5% of having coronary vascular disease. Okay, they give this number because all the further investigation depends on this probability. Okay, and then in 1993, that according to the Duke classification, they thought that not only the age and sex and the type of chest pain, patient risk factors also affects the probability of having coronary vascular disease. Therefore, basically they got risk factors as diabetes mellitus, smoking and hyperlipidemia, and they gave a new chart. In here, if you see in the left side, age under 35, for the men they have given two numbers, 3 and 35. 3 is the patients with without risk factors, and 35 is the patients with risk factors. That means if a patient, 35-year-old patient with comes with non-anginal chest pain with a diabetes and hyperlipidemia or diabetes only, the patient has 35% of having coronary vascular disease. And further, in 2019, European Society of Cardiology, they added to the age, sex and risk factors the dyspnea also as a clinical symptom. They have given a separate column for the dyspnea. Okay. And ultimately the probability, mainly the various guidelines, American guidelines, European guidelines and NICE guidelines, they gave different numbers, but basically they divided the probability as very low if the probability is less than 5%, low if the probability is 5 to 20%, but European they get 10 number, and intermediate 20 to 90%, and high means more than 90%. Okay. Based on this probability, all the investigations, as I said earlier, should be planned. That means more than 90% means patients have more than 90% chance of having coronary artery disease. Therefore, that patient does not need basic investigation. We have to directly send this patient for coronary angiogram to see the coronary vessels, and if there is narrowing, we have to open it. And the other side, very low means less than 5% means patient is very unlikely to have coronary vascular disease. Those patients does not need any investigation to exclude obstructive coronary artery disease. The intermediate group is the one who need further investigation. Okay. Then what are the things we can do for those patients? We commonly call those patients should undergo functional test. Functional test means, as example, is exercise ECG, dopamine stress, cardiac MRI, CT scan, all are functional tests. Basically, we make heart stress by mechanically or pharmacologically, and then assess patients' clinical symptoms, ECG, blood pressure response, heart rate response to assess their underlying coronary vascular disease. These are the available functional tests: exercise ECG, exercise stress echocardiography, nuclear scan, cardiac MRI, coronary CT angiogram. Currently, at Nuwara we have only exercise ECG and CT coronary angiogram. Okay. Few more things regarding exercise ECG. This is the basic test. It's a very non-invasive, freely available, cheap test. Only less trained staff need compared to other tests. The problem of this test is it has very low sensitivity. That means sensitivity is 70%. In 30% of chance we can wrongly diagnose. Even there is coronary artery disease, it cannot be detected in exercise ECG. At Nuwara we have 2 exercise ECG machines, exercise machines. However, we do exercise ECGs at only 2 days per week. In 3 days we are not doing because of lack of human resources. And our exercise ECG waiting list is more than 6 months, I think. That is, I hope that is not acceptable. And in private sector, we don't have exercise ECG. That is also a big problem for Nuwara. The patients at private sector have to go to Kandy to get down exercise ECG. That is the most simple, freely available test. Okay. Then CT coronary angiogram, this is the rapidly developing investigation related to assessing coronary vascular disease. It is a non-invasive test again, and we can assess coronary anatomy. Basically, that means directly we can assess the atherosclerosis plaque in the coronary artery. It basically uses the CT. It needs high temporal and spatial resolution machines. That means we cannot use all CT machines available in this country to do the CT coronary angiogram. Only few newly purchased machines only able to do a cardiac CT. And we all know that radiologists must know that it's very difficult to get a moving objects picture clearly. Coronary artery assessment is therefore it's a challenging. What is always moving, and coronary artery size is very small. It's a 3 mm diameter, and the length is usually 4 centimeters. Therefore, it's a very challenging thing to do the coronary CTs. Anyway, now we have high-tech CT machines to assess coronary artery. This is one of the picture. It shows the reconstructed image of the coronary artery by doing a CT, and it can see the anatomy, and then it can give the calcium deposition in coronary arteries, and whereas we can directly assess the degree of stenosis. Yes, yes. We have, like at Nuwara, we have a CT machine which which can be used to do CT coronary angiogram. However, we are not using that CT machine. In Sri Lanka, I think only NHSL, Anuradhapura and Kandy have CT machines which can do CT coronary angiogram. We are not doing CT. I think that is a complete wastage of our resources. But the CT machine, I think limitation is the good CT machine and the trained staff should be there. And I think for Nuwara the problem is we don't have trained staff to do CT, and it uses radiation and it uses contrast. Some special situations we cannot do CT coronary angiograms. And indications, as I said earlier, according to the probability, the patients who had intermediate to high probability of having coronary artery disease, CT coronary angiogram is indicated. And in NICE guidelines, all chest pain patients, first line investigations, their recommendation is not exercise ECG, CT coronary angiogram. But in European and American Heart Association, they recommend exercise ECG as the first line, and for some patients CT coronary angiogram.